Thank you very much, Aaron, and thank you all for coming out this evening for this event. It's an honour to be here and to be invited to address colleagues in this part of Australia. Like Aaron, I'd also like to specifically thank Viv Miller and Alan Rosen and Ashley Wood and all the others involved in the Mental Health Service Conference for the invitation and the support in coming out here. I'm one of the founders of the UK Critical Psychiatry Network. This is a group of practicing psychiatrists. We're all jobbing psychiatrists struggling with the day-to-day work that everybody else is involved with. We came together in the city of Bradford in the north of England about 15 years ago. Initially, we were just a handful of colleagues, but there are now over 200 psychiatrists, mainly UK-based, but there are people in Australia involved as well, involved in an active email discussion forum. We don't agree on everything, that's for sure, and some people have very different ideas, but there are a number of concerns that draw us together and have brought us to adopt, or brought us to a position in which we engage critically with some of the assumptions, values, and practices of our profession. In my keynote address at the conference tomorrow morning, I'll be elaborating on the various dimensions of critical psychiatry and presenting and trying to do the job of presenting critical thinking not as a negative anti-psychiatry force, but as a positive, indeed necessary element in the development of psychiatry as a mature and confident profession. In this talk tonight, I'm going to argue that psychiatry is going through a crisis of confidence at present. I'll argue that this is due to the inadequacy of what I would regard as the underlying technological paradigm that is dominant, that guides our thinking at present. This paradigm is centered on an epistemology, or a theory of knowledge, that is basically reductionist in nature, and I'll explain that. And I will argue that the research domain criteria that is now being promoted, particularly by the US National Institute of Mental Health, and is gaining support around the world as the kind of way forward for psychiatry, I will argue that this is even more reductionistic than what we've had up to now. And I'll argue against that trend. I will suggest that we need to foreground what I would call the interpretive aspect of our work as psychiatrists, and that this will require a different sort of epistemology, and I will use the word hermeneutic and explain what I mean by that in my talk. And I will finish with some brief thoughts about what a more hermeneutic psychiatry might look like. And hopefully it'll stimulate some questions and we might take it further. It's based on a paper that will be published in the next Journal of World Psychiatry. It's an invited piece, and that'll be out, I think, in October of this year in World Psychiatry. So the paper is pretty much based on what's going to be published then. I believe that the American psychiatrist Ron Pease speaks for many in the profession around the world when he says, in a recent blog, he says, most psychiatrists and many patients sense that psychiatry is in trouble these days. The reasons are complex but boil down to a crisis of confidence. Many in the general public, if they ever had faith in psychiatry, have begun to lose it. Many psychiatrists who, like me, began their careers with hopeful idealism are now expressing pessimism or cynicism. Here, too, the reasons are complex and have much to do with the sense, as he says, that psychiatry has drifted away from its core values and central mission, the relief of human suffering and incapacity. As Pease says, the reasons for the current crisis are complex, but the following seem to be important factors. First of all, I'd mentioned the launch of the DSM-5 by the APA last year, saw the chairs of both the DSM-4 and DSM-3 task force, amongst many others, raise serious questions about the whole DSM process. In fact, far from being the occasion of a joyful celebration of psychiatry's progress, the launch of DSM-5 only served to undermine the credibility of the profession in many ways around the world. I was at a meeting in the Maudsley Hospital in London when the people who wrote the DSM-5 were over for a debate about it, and British psychiatrists were trying to distance themselves very quickly from what they were seeing coming across the Atlantic. And it was quite an interesting meeting to be at. Secondly, while the corruption of evidence-based medicine by the marketing strategies of the pharmaceutical industry is by no means limited to psychiatry, it is also clear that psychiatry has been a particular target of pharma. Peter Guernica, the Danish co-founder of the Cochrane collaboration, in his recent study of the corruption of medicine as a whole by the drug industry, says that psychiatry is the drug industry's paradise. I believe that we have been seriously damaged by our involvement with pharma. Thirdly, there's also an emerging realization that academic psychiatry's attempt to transform itself into a sort of applied neuroscience has not been realized. Alan Francis, the task force leader for DSM-4, wrote recently in the Psychiatric Times, he says, "The neuroscience and genetic revolutions have been astounding in their technical virtuosity and fascinating in their findings, but to date have not helped a single patient. We have learned a great deal in basic science, but nothing at all that translates to better care." Another prominent senior psychiatrist, Arthur Kleinman, someone who I believe has a great deal of standing in our profession, has reflected recently, academic psychiatry has become more or less irrelevant to clinical practice. Far from being a boost to clinical practice, there are signs that in the era of neuroscience, clinical practice is actually deteriorating. In the US, where the practice of psychiatry has been most dominated by DSM, neuroscience, and the pharmaceutical industry, a great deal of clinical work would appear to become simply equated with the prescription of drugs. The New York Times carried a fascinating, but to my mind very sad story in 2011, in which a psychiatrist, Dr. Donald Levin, spoke of having to train himself away from listening to his patients talk about their lives and to focus instead on giving them a DSM label and a prescription. He had to teach himself to react differently to his patients, and, as he put it himself, I had to train myself not to get too interested in their problems. I believe our discipline is in trouble. There are ethical, cultural, and financial dimensions to the current crisis, but one of the most important difficulties is around the perennial question of what is an appropriate epistemology for psychiatry. What kind of knowledge can we have with regard to mental illness, and what sort of expertise is possible in this area? Psychiatry is currently guided by what myself and others have called the technological paradigm. There are three fundamental assumptions involved in this. First of all is the idea that the problems that we're dealing with, the problems to be addressed, have to do with faulty mechanisms or processes of some sort. Most often these are understood as biological processes, but there are also technological versions of psychology which provide descriptions of faulty cognitive or emotional processing underlying various conditions, for example. Secondly, it is assumed that the mechanism or process can be modeled in causal terms, that is, described in a way that is universal, a way that works regardless of the context. Just as malaria is the same whether you're dealing with it in Chile or in South Africa or in Indonesia. It's the same disease entity. It has the same causal mechanisms underlying the symptoms, etc. So too, the idea is that the conditions that we are grappling with in psychiatry have the same form and can be understood with the same kind of causal logic that is used in the rest of medicine. Thirdly is the assumption that the treatments that we use and are often successful with are technological in nature. They're instrumental. It's nothing to do with opinions, values, relationships, or priorities. They fix the faults that are seen to underlie the conditions. That's our understanding, our dominant understanding of what we do in psychiatric practice. The only question to be asked of technology are, does it work, and is it cost effective? The technological paradigm involves at its heart a commitment to what we might call reductionism. When it comes to mental illness, reductionism involves the belief that while social factors and relationship issues may well be involved, ultimately, mental illnesses are the result of faulty neurological or psychological processes, full stop. This is where we should focus our research efforts. Ultimately, our social interactions and our different psychologies can be explained by way of reference to the brain and neurology. 2 weeks before the publication of DSM-5 last year, the director of the US National Institute of Mental Health, the world's largest funding agency for mental health research, Thomas Insel, made it clear that the agency was withdrawing its support for the DSM and that it would no longer fund research projects that relied exclusively on DSM criteria. Insel explained, he said, the weakness of the manual, that is DSM, is its lack of validity. Unlike our definitions of ischemic heart disease, lymphoma, or AIDS, the DSM diagnoses are based on a consensus about clusters of clinical symptoms, not any objective laboratory measure. Instead of the DSM guiding research, Insel and his colleagues at the NIMH launched the Research Domain Criteria project, which aims to develop a classification system that is based not on symptomatology, but on genetics and neuroscience. This is now being promoted as the future of psychiatry and is receiving a great deal of attention. The Research Domain Criteria project is fully committed to reductionism. This is Thomas Insel again. He says, mental disorders or biological disorders involving brain circuits that implicate specific domains of cognition, emotion, or behavior. Simple as that. Everything can be accounted for by the biology of the brain. Furthermore, it assumes that the dysfunction in neural circuits can be identified with the tools of clinical neuroscience. Central to this reductionist approach is the assumption, the fundamental assumption, that the mind is simply another organ of the body, or that it can be equated with the brain. In this understanding, meaning is generated internally within the brain or the mind. It is viewed as something that emerges from a series of underlying neurological or cognitive processes that are open to scientific investigation and explanation. Meaning, therefore, is something that can be explained fully in the terms of cognitive or neuroscience or cognitive models. And I believe that these approaches are simply inadequate, and they leave us high and dry. One of the major insights of 20th century philosophers such as Wittgenstein, Heidegger, Merleau-Ponty, and others was the realization that meaning is not something that happens inside the individual mind or brain, but something that comes into our lives from the social practices that shape the world around us. It is in and through this world that we grow and become human beings and come to know ourselves and others. Social practices generate a context in which our words, our experiences, indeed our lives have a meaning. For example, the man or woman being tortured faces physical pain, the tearing of flesh and screams of agony. So too does a mother in childbirth. A pain questionnaire administered in both scenarios will record similar scores very often. And yet there is a major difference. The context of motherhood is usually rich with love and hope. The suffering of childbirth has a positive meaning and can be integrated into the mother's life. This is seldom the case for those who endure torture. The context of their suffering is very different, despite the fact that in both cases, the physical pain will have been mediated through similar centers in the brain and similar neurotransmitters will have been released. Even the most sophisticated neuroscience will not help us to understand the meaning of pain in the life of any particular person. And it is the meaning of the experience that will determine the longer-term outcome. This is also true of most of the experiences with which our patients struggle. As psychiatrists, I believe that our work is about making sense of experiences such as low mood, suicidality, voices, paranoia. This requires attention to contexts and the use of empathy. With the tools available to us, listening, coupled with the specific insights of phenomenology, psychology, neuroscience, yes, and the social sciences, and the specialized insights that we have been given through our medical training, we can sometimes begin to grasp what is going on for our patients. This is rarely definitive, and all psychiatrists have to live in their work with ambiguity and uncertainty. I contend that good psychiatry involves a primary focus on meanings, values, and relationships, both in terms of how we help our patients, as well as identifying from whence their problems arise. This is not to deny that psychiatry should be a branch of medicine, or to say that other doctors sometimes don't deal with problems of meaning. Of course they do. However, interpretation and making sense of the personal struggles of our patients are to psychiatry what operating skills and techniques are to the surgeon. This is our stuff. This is what makes psychiatry different from neurology. When we put the word mental in front of the word illness, we are demarcating a territory of human suffering that has issues of meaning at its core. This simply demands, I believe, an interpretive response from us. And I think that many psychiatrists would recoil from the idea that they should train themselves to be uninterested in the problems of their patients, as the New York Times interviewee described. The term hermeneutics essentially refers to the theory and philosophy of interpretation. Hermes was the Greek messenger of the gods. He brought messages back and forth between them and also acted as a sort of mediator. The term hermeneutics was first used in relation to interpretation of the Bible, biblical studies. For example, Christian and Jewish scholars have different traditions and approaches to the interpretation of biblical stories. Comparing and contrasting these approaches and the whole effort to find a common language for comparison is what was involved in biblical hermeneutics. In the 20th century, a number of philosophers pointed to the central role of language, meaning, and interpretation in all human domains. And thus the term hermeneutics has taken on a much broader set of references in recent times. The prominent German philosopher Hans-Georg Gadamer is probably the philosopher most associated with the theory of hermeneutics. In a famous address to the American Psychiatric Association in San Francisco in 1989, Gadamer suggested at that time that his whole life work, the idea of hermeneutics, is particularly relevant to the work of the psychiatrist. By adopting a hermeneutic approach to epistemology, we can attempt to understand the struggles of our patients in much the same way as we might understand a great work of art. Bear with me on this. This is the famous 1937 painting Guernica by Pablo Picasso. This was painted in response to the bombing of the Basque town of Guernica by Italian and German warplanes in 1937 in the middle of the Spanish Civil War. Think about it. How do we grasp the meaning of this painting, this human production? We need to understand what's happening on the canvas, how the artist manages to create a sense of tension and horror through the way he uses line, color, and form. We also need to understand where this painting fits in relation to Picasso's artistic career, how his work relates to the history of Western art, and the political realities of his day that he was responding to in the painting. In other words, the meaning of the work emerges in the dialectical interplay of all these levels and also in the response of the viewer. The actual physical painting is necessary, but not sufficient to generate a meaningful work of art. A reductionist approach to art appreciation would involve the unlikely idea that we could reach the meaning of a painting through a chemical analysis of the various pigments involved. There are a number of implications and challenges from this analysis. First, our identity as practitioners. If we move, as I'm suggesting we need to, from reductionism to hermeneutics or something else, something interpretive, as our core identity, we are reasserting the centrality of meaning, context, and interpretation in our work. This will be a challenge given the direction psychiatry has been headed in recent years. But I believe that many psychiatrists are drawn to mental health work because they are comfortable with its messiness, with its ambiguity, its contradictions. These colleagues have felt uncomfortable with the DSM-dominated, drug-orientated, reductionistic version of psychiatry that has been dominant for the past 30 years, and I believe are searching for a move beyond the technological paradigm. In an oft-quoted 2006 paper about what developed countries may learn from the developing world about dealing with stigma, our colleague Alan Rosen here reports on the finding of Tanya Luhrmann, an anthropologist who looked at our profession, or the American version of it at least. Alan writes that she shows how Western psychiatrists, while trying to destigmatize psychiatric illness by promoting its medical nature, have actually participated in the destruction of what attracted many of them to the profession in the first place, the chance to personally engage and heal. Western psychiatrists, she says, appear to have lost their souls to the quest for the fixable, perfect brain and the economic imperatives of the pharmaceutical industry and managed care. It is interesting that many GPs now are discussing the importance of narrative work in primary practice. And I saw an interesting paper recently asserting that oncology, which is very much about being guided by the particular circumstances of the patient's life, should begin to frame itself as a hermeneutic process, a hermeneutic part of medicine. Hermeneutic psychiatry is not anti-medicine or anti-psychiatry, just the opposite. By developing an adequate way of theorizing and engaging with the complexity of our work, it could, in time, I believe, offer insights and leadership in this area to other parts of medicine in their struggles with meaning and interpretation. The central focus of our research cannot be the brain. We should, I believe, leave that to the anatomists and physiologists. Our focus should be on that territory where the human body, including the brain and the endocrine system, meets the social world of language, culture, and relationship. Neuroscience offers us powerful tools, but it will never be able to ground a psychiatry that is focused on interpretation and meaning. As Nicholas Rose and Abi Rashid, who wrote in a wonderful book recently about a very positive book about neuroscience and its role in our society. They're sociologists, but they make the point that the neurobiological project in psychiatry finds its limits in the simple and often repeated fact Mental disorders are problems of persons, not of brains. Mental disorders are not problems of brains in labs, but of human beings in time, space, culture, and history. When it comes to training, a hermeneutic psychiatry will place a great deal of emphasis on the toleration of ambiguity and contradiction, something we've tried to get away from, run away from in the last 20 years. Negotiation skills will be to the forefront of what we teach. We will want our trainees to spend time with service user organizations so that they can learn the skills of getting alongside rather than just checking for symptoms. Lastly, I believe that we will start to value critical thinking and find ways of nurturing the examination of values, assumptions, and practices. We will not see this as a negative distraction, taking our focus away from the real work of neuroscience and prescribing, but as central to our work of helping people make sense of what is happening to them. Thank you.